Welcome to EHJ Today, at the annual meeting of the ESC 2014. I am Filippo Crea, Associate Editor of the European Heart Journal, and I'm sitting with Professor Montalescaut from Paris and Professor Armstrong from Canada. Professor Montalescaut is the PI of a very interesting trial of ticagrelor, pre-hospital versus in-hospital in patients with STEMI. Jay, can you tell us more about the background of this trial?
Yes, Filippo, as you may remember, the concept of pre-hospital administration of antiplatelet therapy in STEMI started 15 years ago with glycoprotein 2B3 inhibitors. We tested that hypothesis in the Admiral study. We had better coronary perfusion before angioplasty. We had better outcomes in this study with pre-hospital administration of abciximab. Now we have this new oral P2Y12 antagonist, prasugrel, ticagrelor. The guidelines say we should use these drugs as early as possible, first medical contact, class 1 recommendation, but no data. And actually this study is the first study to look at this concept applied to ticagrelor here, pre-hospital, first medical contact versus administration in the cath lab of the same drug, same dose. And we looked at two primary endpoints, which were coronary perfusion on the basis of ST segment resolution and TIMI flow before the procedure of angioplasty. And of course we looked also at clinical endpoints in this study. But we wanted to validate the guidelines in some way.
Did you manage?
I think we did. We recruited almost 2,000 patients. We randomized them, 13 countries, 200 centers, 500 investigators, a lot of work. And at the end, the patients were, I think, very well treated, rapidly transferred. And I was shocked to see that the time frame between the two study groups, the median time difference is only 31 minutes. So 31 minutes to bring this patient in the ambulance, give the drugs, drive the ambulance, get to the hospital, get the patient out of the ambulance, get to the cath lab, get a new EKG, and give the second loading dose, 31 minutes on average. And with this time frame, we didn't see an improvement of coronary perfusion before PCI on the EKG and on the cinefilm. We started to see the platelet effect. We had the platelet function substudy and the effect on ST segment resolution after PCI, 1 hour later. And altogether, what we observed is a significant reduction of stent thrombosis after PCI. So altogether, it makes sense. We have a later effect than what we expected because of the short transfer times, I guess. And we have an impact on the iatrogenic complication we do not like, which is stent thrombosis.
What about safety, bleeding?
Safety was fantastic. There was absolutely no difference according to 5 sets of definitions of bleeding. So there is no downside.
Paul, what about you? What are your interpretation of these results?
Well, first of all, Gilles is a pioneer in this area, and these pre-hospital studies are challenging, difficult. And to some extent, as he suggested, he and his colleagues may be a victim of their own success because these patients were relatively low risk, very well treated, and had very low event rates. Moreover, the interval, if one is going to make a difference in a pre-hospital administration of therapy, the question would be, what is the appropriate interval to give enough time to show a difference? And I think because he and his investigators were so prompt, so quick, the time window, which was much longer in Admiral, and indeed much longer in the on-time study that one of his colleagues, Arnold van Hoff, conducted, I think that shrunk the opportunity to show a difference between the two therapies. I guess my other reflection would be he set the bar very high, 70% ST resolution. Some of us would have been more generous. The guidelines would suggest 50% or some continuous variable. And I always hate to disagree with a gentleman, but Professor Montelescu is indeed a scholar and a gentleman, but I'm not sure that the stent thrombosis finding is treatment-induced as opposed to by chance, because if you look at his other endpoints, they don't track the stent thrombosis. Mortality, if anything, is the other direction. The MI not so convincing, but it may be a signal, but I think also, and I suspect he would agree, could be the play of chance.
Is a secondary endpoint?
It is a secondary endpoint, Filippo, but there is no study looking at stent thrombosis as a primary endpoint. This study has never been performed. So stent thrombosis has always been a secondary endpoint in all the STEMI studies. So either we stop talking of stent thrombosis, or we look at stent thrombosis as a secondary endpoint. There is no other option.
Did you find any difference in 2B3 antagonists for bailout?
It's a good point. There is a trend. There is a 2% absolute difference for the bailout use of 2B3 inhibitors when you get late ticagrelor. And if you look at the reasons, the slow flow in the coronary artery occurred much more frequently in patients with a late administration of ticagrelor. So it's one additional point. MIs goes in the right direction, but diagnosis of a new MI when you're in the middle of MI is not easy to diagnose. And there's, Paul is correct, there is a trend in the other direction, but we have looked at all these deaths, and it's very impressive. They are not related to ischemic endpoints or bleeding endpoints, not at all. They are all related to cardiogenic shock, cardiac rupture, sudden death. I think that's one of the problems that we face with the pre-hospital studies. We say we don't want shock patients. And when they see the patient, randomize the patient is not in shock. But during transfer, he becomes in shock. And we have more of these patients in the pre-hospital group, and they pay the price in terms of mortality.
Will this result change your practice?
I think Gilles and I both have reflected on the impact of ticagrelor and the degree to which there's early separation of the curves in the Plato study. He was very much involved as an investigator. I actually did the core laboratory assessment of the ST segment resolution. And one of the striking things about the Plato study is that the benefit of ticagrelor over clopidogrel occurred after the first 24 to 48 hours. And so, to me, the impact of ticagrelor early is an open question. And I think the earlier the better is still probably a good solution and a good recommendation. But I'm not sure that this study has changed my thinking about that issue. And I think this issue of where ticagrelor plays its major role in acute ST segment myocardial infarction is an open question.
Did you assess CK release as a surrogate endpoint?
Yes, it was part of the definitions of MI. We looked at this. We used also various definitions of MI. Everything was adjudicated independently with the definitions that we had provided to the adjudication committee. Altogether, my impression is that there is no downside to use it early if you can use it early. There are many places in the world where the transfer times are much longer than what we have in this study. And what we start seeing on platelet function, on the electrocardiogram, on stent thrombosis, 1 hour, 2 hours after PCI, if you think of transfer times of sometimes 1 hour 30 minutes and not 30 minutes or 2 hours, we should see a larger benefit in the real world if we apply this.
Last very short question. Will this study change next European guidelines, in your opinion?
No, because they already say as early as possible, first medical contact. I don't understand how they came to this recommendation, but at least they have one study now supporting this recommendation.
Conclusion. Well, I wish to thank Professor Montelescu and Professor Armstrong for this really very interesting conversation at EHJ Today.